The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. There are some topics that, as we've talked about over the years, that I think deserve to be revisited. And about 3 years ago, we talked to Kirti Sivakoti about POTS. And I don't know about all of you, but in my mind, it's something that I'm still working on quite a bit. And I think I see more of it because I'm looking more for it. But I needed a refresher. And since this is my podcast, I said, hey, let's have a refresher. Welcome back to the podcast, Kirti.
Thank you for having me.
We're delighted that you made time for us. You've been here now for 3 years, settling in okay?
Yes, it's great. I love it.
Good. You've been a great resource to have around. But before we start, do you have any disclosures?
I don't.
Okay, well, we'll work on that too. So let's start off kind of fresh. We're going to be covering a lot of ground, but I think expanding significantly on that. So let's start off. What are the current diagnostic criteria for POTS? What is POTS?
Yeah, so POTS, it stands for Postural Orthostatic Tachycardia Syndrome. And it's a constellation of symptoms, pretty much feeling crummy when somebody stands up, change in posture. So there are multitude of symptoms, really, and there are so many. Patients can come in with 5, 10 symptoms, more than that. Dizziness, lightheadedness, fatigue, brain fog, nausea. So there are tons of symptoms, but the way diagnostic criteria are worded right now are, we want chronicity of symptoms. So we want symptoms to be there for at least 3 to 6 months before we are calling it POTS. So let's say somebody just had mono a couple weeks ago, we don't want to label them as POTS because they're still within that acute phase. The second thing for POTS diagnosis is absence of orthostatic hypotension. So I think that came mostly from wanting to not have the compensatory tachycardia piece. So let's say there's volume depletion, bleed, something like that. We don't want to capture the tachycardia that is a result of that. We're also looking for excessive heart rate increase. So in adolescents, so less than 19 years of age, it's over 40 beats per minute. And for adults, it's 30 beats per minute. And the fourth criteria that they talk about is there should be reasonable workout to rule out other causes of tachycardia. So like anemia, thyroid disorders, things like that. And we don't have to go on a hunt, but as long as they're reasonably excluded, I think we can start leaning in towards the diagnosis of POTS.
Okay, we'll go into that with a little bit more detail in just a little bit. So as with diagnoses that come with a set of criteria, it's difficult, isn't it? Because there's some diagnoses, I think we can all think of several, where I would say, I kind of think that this is what it is. How is it that the diagnosis can be more complicated than having a set of criteria might make it seem?
You're right. I think there are benefits to having diagnostic criteria, but there are also downsides to having the criteria. And I think it's helpful to have that cutoff because it has helped us at least define this condition and create a common language around, I think, institutions and research. But there are so many pitfalls to the criteria as well. It's based off of heart rate criteria, which first of all, there's so much physiologic variability to it. Heart rate per se can change based on somebody's hydration. There's diurnal variability. If the vitals active stand is done in the morning versus afternoon, there's variability there. Phases of menstrual cycle, their salt intake, if they were sick, if they did not get enough sleep. So it's very variable. And I think that is super challenging because if somebody's heart rate elevation is 35 beats per minute and the next day it's 42 beats per minute, it's not that there's different physiologic process going on. It's probably the same thing. So I think that is really hard. And also, unfortunately, those who are not meeting the classic textbook criteria they don't get told about the treatment options that are out there. They're not told. They're not given a diagnosis. They're not given the treatment options, the resources that are out there. So it's really hard that way. The other thing also is the orthostatic hypotension piece. We have a ton of patients who are hypermobile and they have lots of blood pooling and they have hypotension. Their drop in systolic blood pressure is over 20, diastolic drops over 10, and then they have the tachycardia component to it as well. So that portion of the diagnostic criteria is still, I think it's being debated right now. So I think we're definitely getting to this place where we are recognizing that there are these patients who don't meet the criteria but have the same level of functional impairment. They exist, and they should ideally get the same treatments too.
I'm going to ask a question that I think is a little bit of an expansion on what you just asked, because I think one of the things that we always want to rely on, I think, is something that generates hard data. So how reliable are orthostatic vitals in the office?
Yeah, so that's a great question. And if you look at the consensus statement, so there are three major ones. There's a heart rate rhythm one, there's a Canadian consensus statement, there's a third one. I'm trying to remember which one that is, but all of them talk about for the diagnosis, it could be tilt table or standing. So a tilt table is not required. An active stand test, orthostatic vitals in office can definitely show us the patterns. But with that being said, the criteria of 40 beats per minute, that is coming out of tilt table data. So what we're doing now is we're taking that criteria and applying it to active stand test, which is not validated in pediatrics and adolescents. So there's just a study that actually came out. This is where they looked at 32 adolescents with POTS. They had 15 controls. And what they found is 28 beat per minute increase is what identified most patients with POTS. So they used a rock analysis in this paper. That was interesting. And that tells us that probably our thresholds for active stand are way lower compared to 40 beats per minute. We definitely need more data. But I think moving away from the hard numbers, the other thing that is going to be super helpful is looking at the orthostatic pattern. So when they're taking the test, do they also get dizzy, lightheaded, they want to sit down, or they have other symptoms along with a pattern of impairment of function? I think that is super helpful in creating a management plan for these patients.
So if I remember correctly, when we talked 3 years ago, the tilt table was still the standard, right? That technically someone should have a tilt table test, which, as you just pointed out, does give you a certain consistency in the way that you're gathering the data, but it also was very much an obstacle because I don't know about most people listening, but I don't have a tilt table in my office. And so I think being able to rely on a test that we can do in the office helps, but it does sort of put us in a position where we have to interpret that maybe a little differently.
That's right. And you're right that tilt table is the gold standard. And I think the difference between tilt and active stand is that we're just slapping somebody on a tilt table and then we're tilting them to 70 degrees. So they're not really engaging their core muscles, their leg muscles, but when they stand up in an office, they're engaging their muscles. And that could be different for different patients. So you're right, there could be some difference there.
So can I argue that maybe that's a more real world test than a tilt table?
You were
Okay.
right that
Okay.
it
Okay.
actually captures more real world. Yeah, you're right. Exactly. But with that being said, I think we definitely need sort of more validation for active stand tests because it's more readily available, it's easily doable, and there are long wait lists for tilt tests. And most patients, they don't need tilt tests unless there are, let's say they're not improving with the first line or even the second line, or there are atypical features, or we have other questions, diagnostic clarity.
I understand there's a new protocol for how you do orthostatic blood pressures, that people aren't sitting and standing for as long as they used to for the test.
Yeah, so for the active stand, what we are doing right now is they lay supine for 5 minutes, and then we get a set of heart rate, blood pressures, and then we ask them to stand up. Different centers do this a little bit differently, but ideally we want to get to 10 minutes, and some places do measurements every minute. But as long as we can do measurements at least 1 minute, I mean, ideally 2 minutes, 4 minutes, if not 3 minutes, 6 minutes. So as frequently as possible to sort of like gather the pattern, that's going to be super helpful. But ideally, we want to go to 10 minutes.
touching back on something we started off with. So we have diagnostic criteria for POTS. Is POTS a binary diagnosis or is it a spectrum of disease?
That's a great question. So my suspicion is it's a spectrum and we have slapped a heart rate criteria on it. So we're making it binary, but it's definitely a spectrum. And we see patients who don't have that tachycardia component, the excessive tachycardia component, and they have the same amounts of functional impairment, can go to school, can socialize, can play, whatnot. And there are patients who have excessive heart rate increase, and some of them might not have as much functional impairment. So we actually did a study at our clinic where we looked at patients who did not meet the heart rate criteria. As we used ICD diagnosis for this. We called them orthostatic intolerance or less than 40 beats per minute. And those were over 40 beats per minute, so the POTS criteria, and we compared their functional means. It's based on a functional disability inventory questionnaire, and their means were very similar. There's no difference. So I think it's definitely a spectrum, but when we have a criteria, which in itself has physiologic variability, I think it makes it harder because that target can move day to day.
We're going to talk about treatment at length next week, but what do we do? What do we do with somebody who almost meets the criteria? It seems to me that there's probably some utility in taking some of the things that we learn from POTS and applying it to people. And you could also say, what do we do with somebody who has, some sort of vague complaints? When should I start thinking about POTS being the thing driving that as opposed to something else?
Yeah, so that's a great question. So for those who don't meet the heart rate criteria, we want to look at first what are their constellation of symptoms. So if they have orthostatic symptoms and there's functional impairment, then definitely treat them the same way. So we do the same things in terms of volume expansion methods and talking about cardiac reconditioning, everything the same way that we do for POTS. And it's interesting you asked about this other group of patients who have these other overlapping symptoms and what do we do with them, whether that's chronic fatigue or brain fog, can't focus. And there is a researcher who has looked into this patient population as well. And what they found is the unifying thing between POTS, orthostatic intolerance, chronic fatigue, all of this seems to be reduced cerebral blood flow. So it drops down significantly, like over 60% in all of these. And I'm hoping that's where the field is moving in the future too, like identifying the cerebral blood flow, other markers. But for these patients, I would let functional impairment be the guide. So if they are so functionally impaired that they can go to school, can do all the things, then we would treat it the same way as we would treat POTS. With that being said, depending on what are their dominant symptoms. For some, it could be GI symptoms are very dominant. For some, fatigue is very dominant. Yeah. So I think we would mix and match therapies. We can get them back on the path of functioning.
Let me ask you a question that we ask, I think, about several problems that are in sort of a similar area. And that's the tension between, are we over medicalizing normal physiologic variability, or on the other hand, are we under recognizing the significant impairment that comes with this set of symptoms?
Yeah, I think it's a little bit of both. Probably the second a lot more. So in terms of patients who have physiologic variability, I think an ideal approach would be when I see those patients in clinic and they just talk about, well, I get dizzy sometimes, I can still go to school, I can still play games. Maybe I'll have to take nap once a week, something like that. I don't even do an active stand test. We don't talk about labels. We just talk about maybe go run on the treadmill a little bit more, maybe drink a little bit more water and fluids and more electrolytes and leave it at that. We definitely, as when we are learning that the functional impairment is not much, it's better not to over medicalize them. But on the flip side, I think the risk is under medicalizing the ones who are struggling. And I think there's a tendency, and especially in medicine, we catch disease really well. And if you're seeing patients who are, let's say, wheelchair bound, significantly functionally impaired, it's easier for us to help them out. But those who are first struggling quietly, the ones who are still in school, but they come home and they take a 4 hour nap, but now they don't sleep at night, or the ones who have to pick and choose their energy, those ones are the ones who definitely keep getting missed. So I think understanding the functional burden, how it is for our patients and addressing that's super important.
And it's empowering to be able to have something to do.
Yes. That's right. Patient we talk about is the best thing, is the best solution. So
Yeah, and I don't want anyone to misunderstand me there. I'm not saying that, we're throwing them a bone. What I'm saying is that I think that as we address symptoms and give someone something to do to intervene in those symptoms, that kind of is the essence of medicine in a way, of helping people to be better.
exactly. It's like giving them tools at their point of performance. So if their thing is they nap for 2 hours after coming home, just helping them with those environmental structures, things like that can help them delay, or giving them some tools to help with fatigue. You're right. So just helping them with some tools can be really life changing for them.
You've already alluded to this, but can you help me sort out in my mind how I differentiate POTS from vasovagal syncope, vasovagal syndrome?
Yeah. So POTS and vasovagal syncope. So that eventually what we're seeing the outcome, it looks very similar, but I think the underlying mechanisms, the processes are very different. So with POTS, we think about this as a syndrome of chronic orthostatic intolerance. So there's more, they stand up, they feel dizzy, and some of them faint. Well, the other misconception about POTS too is that it's a fainting disorder, where actually less than a third of patients faint. Most of them get dizzy. Syncope, on the other hand, is more so, it's like a reflex, vasovagal mediated process with a sudden drop in blood pressure, drop in heart rate, and then they just faint. But in POTS, essentially, their blood pressure overall remains normal. The hypermobile subtype is to be debated for their slight drop, but overall it remains normal. And then they have chronic orthostatic. There's definitely overlap. There are patients with POTS who could have syncope, patients who just have syncope, but we don't see syncope necessarily more in patients with POTS.
Do the two problems coexist?
Yes, they can coexist. I think it's important to separate them out, at least so we're not missing some of the diagnosis, like cardiac dysrecurrence. It could be like cardiac arrhythmias or seizure
Okay.
disorders, things like that. So we can direct referrals appropriately. But I think outside of that, once we have ruled out dangerous things, I think focusing on functioning is super helpful.
Let's talk a little bit about what we know about the etiology of POTS. So, one of the things you've alluded to a few times already is volume expansion. Is there a reason why people with POTS have hypovolemia, or at least relative hypovolemia?
That's a great question. With regards to the etiology, there are so many different mechanisms that are out there. Why patients have relative hypovolemia? We don't know the answer for sure, but then there are some theories out there. So the mechanisms that we think about with POTS is there is some sort of susceptibility in this population, and then there is a trigger, whether we can put our finger on it or not. So it could be infection, post-infectious, so COVID, mono, influenza, post-concussive, post-surgical, sort of like periods of prolonged bed rest. But whatever that trigger's doing, maybe one of the processes we think is that altering a renin, angiotensin aldosterone system, and is that leading patients to a place of relative hypovolemia. Other mechanisms is that the period of enforced bed rest or deconditioning, is that
Oh,
leading to, yeah, so there are some of those processes, and some of these patients, well, actually, a lot of them have GI issues as well, disorders of gut brain interaction and eating disorders, food intolerances, gut motility issues. I think for them to have a good intake is also challenging. So when they can get to the fluid goals, that also keeps them in a place of relative hypovolemia.
so let me back up on that a little bit, because this is a tall order, and I think you've begun to elucidate that. So you say the gut-brain interaction may come from various reasons. One may be that if you're not getting enough, then your brain is going to protest about that. But are there also things about what we're beginning to understand about how the gut regulates many things in the body? Is that part of it too?
Yes. So, well, when we think about POTS, it's a state of sympathetic activation, like a fight or flight mode. So our rest and digest system is
Oh,
pushed corner. So one of the thoughts is, are we not able to digest well? Or is there a motility issue just because we are in a fight or flight mode? But the other things that we think about, is there autonomic denervation? Is there injury to the autonomic nerves that supply the gut, whether in the stomach or the colon, the small intestine, and that's regulating motility? Or is it a signaling issue? There are some patients when they are defecating, they vomit. Or there are some patients who wake up at 2 a.m. and they vomit. So there could be just a signaling issue in these patients as well.
So with the impaired pathways, is that one of the things that would go toward explaining both post-infectious etiologies as well as autoimmune etiologies?
Yes, is our thought, and there's a lot of research going on with regards to the autoimmune, the post-infectious etiology. So a lot of it is in the experimental phase right now, but clinically we see all these subtypes, and it's that we don't know what to do with them because we don't have
Well,
tailored therapies. But yeah, we see post-infectious, post-concussive, and it's also very interesting how they respond to different treatments.
so because it sounds like you're describing in some instances that, or in many instances, that there's a hyperadrenergic state. And I think sometimes we think of that as a secondary thing, but are you suggesting that sometimes that's a primary issue?
So with hyperadrenergic state, I think there are a couple different ways to look at it. Under the umbrella of POTS, I think there's a subtype of patients who are like primarily hyperadrenergic. They tend to have higher blood pressures, they are flushed, and these are the patients who respond really well to clonidine. Whereas for other patients, we would be super nervous about putting somebody on medications like clonidine. It's a different subtype, and if you talk to autonomic neurologists, they will say the way to definitively diagnose this is supine and standing catecholamine levels. If there's a 3-time elevation, they meet the criteria for hyperadrenergic POTS. But it's harder to go that path, and management is overall similar except for these subtle differences. But then there's this other, I wouldn't say subtype, but this presentation where patients have autonomic dysregulation, where they could predominantly be in the state of lowish, low normal blood pressure, hypovolemia, and then they have autonomic flares. So sort of like adrenaline dumps. And then now they can't digest and they can't go to school. They're feeling really terrible for like a couple weeks and then they regulate themselves.
Very interesting. So just to wrap up, wanted to summarize a couple of things that it seems where the thinking has maybe changed over the last couple of years. Clearly recognition. I think this is something that people weren't talking at all about. Choose a date in the past, in the not so distant past, and that's true. Is it also fair to say that there's an increased appreciation for the heterogeneity of the disease?
Yes, absolutely. I think we have come so far from is POTS real to talking about POTS, understanding POTS and appreciating the heterogeneity of POTS. And the analogy I use with my patients usually is that think about fever. So having a temperature cutoff under 0.4 is helpful. And these patients have a shared physiology, but that's the same thing that we're doing with POTS, which is we're using heart rate as a marker. But there could be multiple things that could be leading to your POTS. So I think researching POTS is that's why I think hard because there are so many underlying phenotypes and we need to be able to distinguish them.
And then one last question. I realize I'm launching a great big question with this one, but I think there's a temptation sometimes to say, well, you're just an anxious person and this is just anxiety. And there's no question that there is some link with depression and anxiety. How do you have that conversation without having that conversation?
Yeah, that's a great question. And you're right in that a lot of patients shut down when we even say the word anxiety or depression. So the way we have the conversation with our patients is we don't even bring up anxiety and depression. And when we realize that there is a behavioral health target for this patient, the way we phrase it is, well, your body right now is in this place where there is a signaling issue and cognitive behavioral therapy, the targets for those could be, and then we talk about the target. So things could be like it can help with the catastrophizing behavior, school reintegration, or it can help with sleep regulation, or it can help with executive function. So all of those targets. And these can help with POTS symptoms as well. So we don't even bring up anxiety and depression. And if we bring it up, the way we do it, there could be comorbid anxiety and depression, and managing that can also help manage the functioning when it comes to POTS. And there are some good papers, literature that talks about depression being a mediator for functional disability in POTS. So we also share that literature with our patients, and we seem to get better acceptance that way.
It seems to me, in the last while, we've talked to gastroenterologists about functional abdominal pain. We've talked to neurologists about functional neurologic syndrome. And the point is that I think that when we tell somebody it's all in their head, For one thing, I think we tragically misunderstand what's going on for people, but we're also not offering them anything to help with their symptoms. It seems like great advice to say, let's deal with your symptoms, and also find a framework where some of these things that we know help with depression and anxiety. I think that having these sort of symptoms could by itself make you feel depressed and anxious. And so whatever the etiology, giving someone something that helps is a good thing.
Yes, absolutely. And you're so true when we're talking about if somebody gets told that this is in your head, this is so dismissive to patients who
Yes.
so this is their experience
Yeah.
of life, of health. They can go to school. Most of our patients will usually say they wouldn't be sitting in my office if they did have to. These are high achieving teenagers who would rather be in school and do things. So I think it's important to validate for sure and recognize. And I think if we listen more, they're also more likely to listen and we'll have so many more things to offer.
Terrific. Anything else you want to say about the diagnosis of POTS in 2026?
So I think we pretty much covered most of the things, but I think there's this growing recognition of this larger cohort of patients who don't seem to meet the textbook criteria of POTS, but have the same amounts of functional impairment. And I think there is a lot of literature that's coming out on that. We don't have consensus on terminology for this group yet, but there is definitely agreement on the concept that this cohort exists, whether we are calling it orthostatic intolerance or postural symptoms without tachycardia. So, but we know that this cohort exists. And in our clinics, that is actually a larger number than the ones who meet POTS criteria.
Very helpful. Yeah, you know what I think we ought to do? I think we ought to get together next week and talk about treatment of POTS. What do you think about that?
Yeah, that sounds great.
Perfect. For all of you out there listening who have questions, please send your questions to vcurb.com. We would love to get at some of the things that we maybe didn't talk about. Dr. Sivakoti, thank you so much for taking the time to talk to us this week, and we'll hope to get together again next week.
I'm looking forward. Thanks for having me.
All right, great. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.